Welcome to the Pressure Injury Definition Stages Changes to Staging System in 2016. My name is Christine and I will be the operator for today's call. At this time, all participants are in a listen-only mode. Later we will conduct a question and answer session. If you are having web issues, remember that the password is case sensitive. The password is pressure with a capital P, lowercase, all the other letters. If you are having further problems, please call 571-598-1988. Please note that this conference is being recorded. I will now turn the call over to Emily Nelson. You may begin.
Hello, everyone. This is Emily Nelson with the Lake Superior Quality Innovation Network. I'd like to welcome you to the webinar, Pressure Injury Definition and Stages, Changes to a Staging System in 2016. This webinar is intended for providers working with Quality Innovation Networks in Alaska, Colorado, Hawaii, Illinois, Iowa, Kansas, Michigan, Minnesota, Montana, Nebraska, Nevada, New Mexico, North Dakota, Oregon, South Dakota, Utah, Wisconsin, and Wyoming. Because Medistar is providing continuing education credit for this presentation, we need to inform you no commercial support or sponsorship has been received for this learning activity. The speakers have reported no conflicts of interest, and there are no planner conflicts of interest. No products or services are endorsed by Medistar or any accrediting agency. Off-label use of drugs or devices may be discussed during this session. The speaker will indicate during their presentation if they are discussing off-label use. For CE credits or certificate of attendance, you must attend the entire session and complete an online evaluation via the web link. We encourage everyone to complete the evaluation to provide feedback on the session. All lines will be muted during this webinar. At the end of the webinar, there will be a short time for questions. You may also ask questions in the chat box. The objectives for today's webinar include describe the rationale for changing the term pressure ulcer to pressure injury, identify the changes in the 2016 NPUAP staging system, and to identify pressure injury prevention and treatment strategies. We are pleased to have Dr. Joyce Black as our speaker today. Dr. Black is an associate professor at the College of Nursing at the University of Nebraska Medical Center. She is known for her work with the National Pressure Ulcer Advisory Panel, especially in staging pressure injuries and deep tissue injuries. Dr. Black is certified in wound care and is a member of the American Academy of Nursing. Thank you for speaking with us today, Dr. Black. I will now turn the presentation over to you.
Thank you very much. It seems like one disclosure I need to make is I may leave you more confused than clear on what has happened with the staging system, but I do need to tell you on the front end that what you know today as a stage 2 pressure ulcer is a stage 2 pressure injury, and what you know as a deep tissue injury is today a deep tissue pressure injury. So none of that has changed. You will not have to go back to work yet today and go, oh my goodness, we've got to change everything. We did tweak the definitions, and that's what I'm going to talk to you about. We tried to clarify particularly the differences between a stage 2 and a stage 3, between a stage 2 and incontinence-associated dermatitis, and some of the errors in the deep tissue injury pressure ulcer category from the previous, we also tried to fix. So hopefully we accomplished our objectives. Let's see if we can accomplish our learning objectives. The other thing I'm going to talk about at the end is some of the information on medical device ulcers. And so I promise I will leave enough time for questions and answers because I know that there will be some. So the process to make this change actually started in about 2014 at NPUAP. And what we were attempting to get clarified were the existing staging terms. And so we looked at a great deal of literature to see where the people that were using the staging system were struggling, where were the problems, and what else could we clarify simply because we got a lot of questions at NPUAP about these various stages. The task force consisted of 6 people. Laura Edsberg and I were the co-chairs of the group. Lori McNichol, Margaret Goldberg, Lynn Moore, and Mary Segreen were the other 4 members. We developed an early draft, a set of definitions of the proposed changes. in both the terminology for pressure ulcer to become pressure injury as well as the 6 stages of pressure injuries. And we got lots and lots of comments back. In late 2015 into early 2016, we looked at all of those comments and made our final recommendations for the language. It was presented to NPUAP in January of 2016. And then we held a consensus meeting in April of 2016 in Chicago. I suspect that some of the people on the phone were at that meeting, and you can chime in if I don't remember something correctly and let me know. But I think I've captured it all, so hopefully I've got it correct. So since April of 2016, there's been lots of organizations that have endorsed the new staging system. The first group to do that was the Wound Ostomy Continence Nurses Society, and then CMS, of course that's a big one for those of you in long-term care, is looking at it. They are not going to change the MDS 3.0. I mean, we know that. That took 10 years to get that done, so they're not going to change that anytime soon. They expect that when the new one comes out, then they will look at multiple changes in it. The Joint Commission has recognized the work. The Joint Commission is obviously not the one to set the standard for terminology, and so there's a couple other groups that do the electronic numbered system for medical diseases that are looking at it. The World Health Organization has added it to the ICD-11 coding, and there's been lots of other organizations and associations that have endorsed it and are looking forward to implementing it. The only exception is the Association for the Advancement of Wound Care, and they pointed, there have been very pointed negative statements about the use of the word injury. I'm sure if you're into wound care, and why would you be on this call if you weren't into wound care? You've seen some of the editorials that have been published on it, and their fear is, and I'll get to that in the next couple slides, their fear is that it's going to increase litigation, and of course we wouldn't have taken this on as NPUAP if we thought it was going to increase litigation. We have enough litigation. And we've even actually been very pointed about some of the task force members, which we as NPUAP think is really not what we're all about. So why did we go to the word injury? A couple of reasons. Stage 1 and deep tissue injury in the old categories were never ulcers anyway. And so we had a disease name, pressure ulcer, that was not represented by the 6 types of pressure ulcers. Only 2 through Unstageable were actually ulcers. And stage 1 and DTI were never ulcers. And I'm sure that you guys have had this discussion clinically with various people going, you have a stage 1 pressure ulcer. Well, okay, what do I pack it with? What do I put on it? Well, it's not an ulcer yet. It's just a warning sign of an ulcer. Well, you either have the disease or you don't have the disease. So it really never was a good name of a stage 1. And then, as you recall, 10, 12 years ago, we introduced the idea of deep tissue injury being, at least initially, not an ulcer, but purple intact skin. And we recognized that 2 of those 6 were not ulcers at all. So we thought the word injury was more inclusive. And in part because an ulcer cannot be present, an ulcer of any kind, ulcerative colitis, a gastric ulcer, it doesn't matter what the ulcer, is. There has been an injury to that tissue in order to lead to an ulceration. But you can have an injury without an ulcer. So, again, the word injury seemed to be more inclusive of what we were trying to talk about. So, it's a question, is there greater legal exposure? And those of you that have been involved in lawsuits realize how nasty they can become. But I want to focus now on why an issue with the development of a pressure injury, pressure ulcer becomes a lawsuit. And this is the story. The patient or the family has had an unexpected outcome. That should be on if you want to change your slides. I just saw that typographic error. It's an unexpected outcome, which leads to frustration or anger. None of us, well, I'm presuming, I should not be assuming, but I'm presuming that none of us put there's a risk of a pressure injury on the consent form. If you work in acute care and you take a patient off to the cath lab or to surgery, I doubt your consent form says you have a risk of a pressure ulcer or pressure injury developing. So In almost all cases, this is an unexpected outcome. I'm sure there are situations in which the patient or family has been told your patient, your mom, your dad, whoever, is at such high risk of ulcerating that we're going to do all we can, but I can't guarantee it's not going to happen. So there may be people who experience pressure injuries that knew they were coming because of the work that you did. However, the majority of them are unexpected outcomes. The standard of care is not met. That's the real crux of these cases, is that, a set of experts looks at the records that are provided, and they say, well, this is the standard of care in this setting at this time, and the standard was not met, and harm came to the patient. The presumption is that if the standard of care was not met, that if the standard of care were met, the ulcer wouldn't have happened, and therefore the ulcer is considered, or the injury is considered, avoidable. Cases are not brought forth legally because of their name. They don't get to court simply because they're called as something. They get to court because the patient says this shouldn't have happened. An expert looks at the case and says the standard of care was not met, and the standard of care being not met caused an avoidable pressure injury in our case now. So how do we rest on that confidently? And what NPOAP did was ask multiple malpractice attorneys, both on the plaintiff side or the defense side. We did both. I actually did both. And yes, there were attorneys that said, yeah, it's going to make it easier to sue, but it's pretty easy now because all we have to do is find an expert that says the standard of care was not met and the ulcer was avoidable. So nobody said to me, we're going to have business coming out of our ears. Most of the attorneys, however, said to us, it's not what you call it, it's what you did to prevent it. And in fact, one attorney said he hated the word ulcer because it always made people think of bleeding ulcers or stomach ulcers, and he could never get that across. And one of the other attorneys said he didn't like the word bed sore because it automatically said there was pain involved because it was sore. And it made the jury fall into that word. So I guess there's been problems with all the words. When we sent the definitions out to the stakeholders, there were no concerns by any of the stakeholders for the use of the word injury. We have had no concerns raised by people who have already started using the term. And at the end of the day, nobody really knows. When we changed the word decubitus ulcer to pressure ulcer, there was no significant change in case law, even though decubitus ulcer means to get an ulcer lying down, and pressure ulcer was changed to start to teach people about the issue of wheelchair ulcers. So I think I don't see this issue. I see this as a lot of smoke, and hopefully it will. You'll have a chance to look at it in a logical perspective. NPOAP did publish the results of this work in a manuscript in the WOCN journal. I believe it is available at no cost online. So if you want to follow through with what I have said or will say in this lecture, this is the publication that I would direct you to. So let's take a look at that updated staging system. One of the things NPOAP did was commission some new artwork. And I really like the artwork. You can see it on each of these slides. And what I've done in this set of slides is gone through all of the artwork that NPOAP picks up. These slides that you're looking at now are available for purchase at NPOAP if you want to use them in your own education. They actually come as PowerPoint slides, so you can use them however you want to. They're not fixed. So if you would want to put some material into this slide, you certainly could do that. So we know the skin is the largest organ of the body. All of us have skin, and obviously when it's intact, it serves as our primary prevention from the invasion of various microorganisms, fungi, all sorts of things. Skin does lots of other things, but in our case, we're mostly concerned about infection prevention with intact skin. I have to tell you, when I looked at this cube of skin, now obviously as you're looking at it, you're thinking, well, that's not anatomically correct. And I said, no, it's not. Because if that were correct, Joyce Black, the lady who's speaking to you, would be thin with no wrinkles. Because look at how thin that fat layer is, the yellow lumpy layer. And look at how thick the skin is. Skin that thick wouldn't wrinkle. So this clearly is not anatomically correct, but we did this to emphasize what we wanted to emphasize, which is the skin, not the rest of the anatomy. As you can see, the epidermis connected to the dermis with ready pegs, or those lumps, bumps that run through the connection there. Those are what thin as people get older and thin with the use of cortisone. And that's what makes both of those groups, the steroid-dependent and the elderly, at high risk of skin tears. The dermis is divided into two parts. The upper part of the dermis, where you see most of the blood vessels, is very bloody, and the lower part of the dermis is not real bloody. We're going to look at both sides or both halves of the dermis. You can see the fat, the lumpy yellow material. Underneath that, the muscle connected to the bone via tendon, and then the ligaments connecting the various bones. I have to tell you, when I looked at this piece of skin, the first thing I said was, what is that hair doing there? Who has hair in the parts of the body that get pressure ulcers? I mean, except for the head, nobody has hair. Well, I'm glad it's there. We'll show you how it has a very important role coming in, but I hated the hair. In fact, initially, the hair was bigger and longer, and it just looked like something you wanted to just pluck with the tweezers and get it out of there, but it stayed. And it stayed for a good reason. So the layers of the skin, the epidermis is the dry layer, what you can touch on your own skin now, and the dermis is the living layer, which contains the nerves, the vessels, the lymphatics. The two layers of the epidermis are named. The papillary layer is the superficial layer, bloodier layer. When you injure it, you have blood. So a skin tear would be of the papillary dermis, lots of blood in those things. And the reticular layer, the deeper layer, does not have a lot of blood in it, and so you tend not to get a very bloody wound out of it, but it has a different pattern to its appearance. I'll show it to you. The reticular layer is filled with collagen, and that's what we need for healing. So the definition of a pressure injury is there on the slide for you. It's localized damage to the skin and underlying soft tissue. Usually, and if you've got a paper copy, I want you to put a circle around that, usually over a bony prominence. And we all grew up with the definition that pressure ulcers at that time were wounds on bony prominences. And we so adopted that today when we look at a wound from pressure that's not on a bony prominence, we go, well, that can't be a pressure ulcer because that's not on a bony prominence. And conversely, if we look at a wound on a bony prominence that has nothing to do with pressure, we turn around and say, well, that can't be a pressure injury because it's not on a bony prominence. Well, that makes no sense. It isn't where it's at, it's what caused it. So the word usually is the important one. The other thing that got added to the definition is the idea that medical devices can lead to pressure injury. And so can other devices. The group in Chicago asked us to include other devices, like eyeglasses, as a cause of pressure injury. So that got added. That was not in POEP's original plan. The injury presents as intact skin or an open ulcer. You can see how we got after our problem with the old definition here. And they may be painful. The injury occurs as a result of intense and or prolonged pressure, or pressure in combination with shear. These injuries to the skin and soft tissue are from pressure, and therefore pressure must be in the etiology. So if you're looking at a patient's wound, and you cannot for the life of you imagine how pressure got there, then think about another etiology. It's probably not pressure. And shear is the other issue. Shear is a terribly dangerous force. It is literally moving pressure. So patients who sit with the head of the bed elevated in order to be tube fed or breathe have a very high risk of shear injuries. And when patients have shear injuries and continue to shear them, the wound gets worse. We know that the tolerance for soft tissue for pressure and shear may also be affected by a lot of things. Microclimate is the moisture in the skin, nutrition, blood flow, the comorbidities of the patient, and the condition of the soft tissue. Those are things that we often can't do anything about externally. We can help the patient to control their incontinence, to keep their skin dry. We can help the patient improve their nutrition. Where we really see this come to life is when we're taking care of two patients with identical diseases. So brain injury, for example. A young person, 18-year-old and an 88-year-old with a brain injury. Because of all of the other things wrong with the 88-year-old, their tolerance for pressure is much less. And so we see them alterate much more quickly. All I did with this slide is mark the changes in red so that you could see the changes and grab onto them for teaching purposes to your staff. So here's the definition of a stage 1 pressure injury. It's non-blanchable erythema of intact skin. It may appear different in darkly pigmented patients or persons. The presence of blanchable erythema. So this is, if you have something called a pre-stage 1, this would be that. The presence of blanchable erythema or changes in sensation. So the patient may complain of pain. I have patients complain of tingling in their skin. The temperature, in the beginning it's cooler, and then as blood flow gets through it, it gets pretty warm. The firmness, it may be boggy, it may be stiff, depending on how much edema is in the tissue. All of those changes precede the change in color. The color changes do not include purple or maroon, because those indicate least worrisome for deep tissue pressure injury. The group in Chicago asked us to be very clear in each definition that we always said what it wasn't as well as what it is, and so you will see that pattern carried out in the slides. I didn't know who might be listening to these slides, so here's the Blanche response, just using the artwork showing the blanchable erythema being predominantly in the epidermis, and then the non-blanchable being more so involving the dermis itself. And it's tested, at least here in the U.S., it's tested with a finger. In Europe, it is tested with a little plastic disc. I want you to think about those little bitty magnifying glasses you can buy for your kids. You know, they're about maybe 3/4 of an inch thick or wide. And that's called discopy, dioscopy, or discopy. I've heard it pronounced both ways. And what people do is put that clear disc on the skin to see if they can get the skin to blanch, and that way when they release it, they can still see it. Where when your finger occludes it, sometimes it's soft and you just don't see the blanch response. So this is a teaching slide basically telling you how to do a blanch response. I put it in for you to teach your staff if you're working with folks who are not sure what it means to do a blanch response. I presume since you guys do wound care, you know pretty well what that means or how to do it. So this is an example of a stage 1 pressure injury. This is a young woman. She's only about 35. That had an operation, and she was getting off of the operating room table when the staff noticed this area of non-blanchable erythema. Took a photograph of it. So a couple things to notice about the photograph is that it's not on the sacrum. The sacrum would actually be up on top of that gluteal cleft, but it's actually onto the buttocks. And when you look at that, now you may say in your description that's sacrum, but that's actually buttocks, particularly on the right buttocks. She was laying supine on the OR table when the pressure occurred, and she was actually tipped a little bit to the right. Does that make sense? You see that there's greater pressure injury on the right butt cheek, which means she was laying a little bit to the right side on the operating room table. That stripe on her buttocks is actually, there was a fold in the linen on the OR table. So when you look at that, I want you to start thinking about, you know, that you can do more with this story than just say, well, that's a stage 1. You can actually figure out where and when it happened, which is really important when you start to figure out your root cause analysis, because this patient, this happened in surgery. So when we try to figure out, you know, what are we going to do with our continuing ed program next year? Well, you know, we're getting a lot of pressure injuries coming out of the operating room. Let's see if we can work with the OR staff. So important to think about, you know, what position was this patient in at the time pressure was applied. If this patient was not on the operating room table, I'd wonder then where she was. That would lead to that pattern of injury. Pigmented skin is pigmented because of the melanocytes sitting at the bottom layer of the epidermis, and melanocytes produce melanin, which is a pigment, and it absorbs the rays of the sun and prevents or reduces the risk of skin cancers. Lots of causes of variations in skin tone, obviously including sun exposure, the gender, the race, the hormones, the age of the patient. The definition of a stage 1 in darkly pigmented skin is the same as the definition of the stage 1 in non-darkly pigmented skin, but the difficulty we have is in seeing it. And so the pigmentation, depending on how dark the skin is, may keep you, the examiner, from seeing it with your naked eye. A couple of pieces of advice on how to see changes in the skin. One is to moisten the skin, and you could take an alcohol wipe if you want to. You can also take a wet washcloth and just make the skin wet. I don't want you to soak it, but I also don't want you to rub it. So take this wet cloth and just wipe it on the area of the skin you want to examine. The epidermis in darkly pigmented patients is thick, and because it's thicker, it dries, and when it dries, it gets this white cast over the top, and it's hard to see the changes. If you darken or moisten the skin, you can see the redness pretty easily. You also can ask about pain in the area, and then, of course, palpating it for edema, for induration, will help you also identify it. Well, I'm having trouble moving the slides. Let me see if I can get this to go. Molly, can you advance to the next slide? Oh, there we go. I don't know if you did it or I did it. So here's a pressure injury example of a pressure injury in a darkly pigmented patient using palpation. We were able to get a feel for the thickness of the tissue, and you can see in the bottom picture, even though it's a little bit overexposed, an area of darkened skin in a patient who was laying on their back, and so that's a buttocks cheek that you're looking at. The stage 2, I really like the artwork. I hope you like the artwork. It took us forever to get this artwork because we kept saying to the artist, no, we need it to shine, to have a glisten, because the papillary dermis is bloody and even the reticular dermis is somewhat shiny. So this is the stage 2, the artwork of a stage 2 in a papillary dermis. So stage 2 is our partial thickness skin loss with exposed dermis. The wound bed is viable, and we're going to spend a couple minutes on that word. Pink or red, moist, but it also may initially just appear as an intact or ruptured blister. What's not there is visible adipose tissue. You don't see the deeper tissues of muscle, tendon, ligament, any of those things. Stage 2s do not have granulation tissue, slough, or eschar. Those injuries are common. Stage 2s are common in the pelvis when you have patients with incontinence. So we call it adverse microclimate. And we see a lot of shear in patients with stage 2s of the buttocks. So as you're looking at this wound, I want you to think about that combination of problems. You've got not only a pressure problem, you've got a moisture problem. You not only have a pressure problem, you have a shear problem. And so as you lay out your plan of care, you're going to need to think through both of those pieces. So here we're told by the audience, be sure to tell us what it's not. And so stage 2s are not moisture-associated skin damage. So the first one on the left is incontinence-associated dermatitis. And even though the incontinence-associated dermatitis is reaching up to the sacrum, if you look at that most right area on the buttocks, you're at the sacrum there, because of the distribution of redness. Look at the redness in the folds of skin. In fact, you can actually see the folds of skin on the bottom of the picture where, because of either clothing or skin, the urine stool did not get to that area. But you can also see the redness down in between the legs and the upper thighs, presumably also in the perineum. This patient has a history of incontinence, and this wound is actually a burn from the exposure to urine and stool. It's also not intertriginous dermatitis or the skin fold rash that we see in most skin folds. You can see this lady holding up her breasts and exposing all of this area of skin fold rash from the moisture and the heat and the friction of one skin fold rubbing against the other skin fold. And it's not, the term today is MARSI. It's not medical adhesive-related skin injury or traumatic injury in which skin tears are in there. And, of course, the last one is a skin tear. So as you're thinking about, well, gosh, all of those wounds are wounds that expose the dermis. That's absolutely true. Those are all wounds that expose the dermis. You need to be thinking about what the cause is. And so if you cannot figure out where pressure is in that story, then don't think about pressure injury. So if you look at the one in the middle, that's not a pressure ulcer from her breast. If it were a pressure ulcer from her breast, it would only be where the breast tissue is. And you can see in this case, it's actually between the breasts. So it's not got anything to do with pressure. A big part of this story is getting the right picture and the right wound to go together. So I told you we need to talk about the viable dermis. That's the word I put in, and I put it in for a reason. That deep tissue pressure injuries have a non-viable dermis. So when you're looking at a stage 2, you want to look to see if the tissue at the base of the wound bed looks healthy, looks like it's going to heal. So there's the tissue of those are 2 stage 2 pressure ulcers, pressure injuries. I should get my hand slapped every time I say pressure ulcers. Those are 2 stage 2 pressure injuries. You can see the bloody look to it, the shiny look to it, very healthy looking tissue. They're painful, and they can have serous drainage, often serous drainage, not often bloody drainage. So the appearance of a stage 2, this is the reticular layer of the dermis. The last ones were the papillary layer. You see, it doesn't have that red, shiny look to it, but instead, it almost has a yellowish look to it, and that's your staff might call that slough. I'm going to try to explain how it's not slough. This is a patient who's paraplegic, and therefore he uses a slide board to transfer, and he's been a paraplegic for a while. So what he's got is actually quite thickened skin of the buttocks. And I want to direct you to about 3 o'clock, 2 o'clock on the slide. You can see the edge of the epidermis and part of the dermis there. So if you look at that, you think, whoa, that's pretty thick. That's got to be a stage 3. Look at how thick that skin is. But think about the patient. The patient's got very thick skin on top of the ischial tuberosity from sliding on the slide board. Then, looking at the wound itself, I think you can see the dots in the wound. Those are blood vessels. Slough doesn't have blood vessels popping through it. And the last confirmatory piece is it's not removable. You could take a wet Q-tip and try to push that off, and it won't come off. It actually looks like a web when you look at it sometimes. But if you take a wet Q-tip and push it off, you won't be able to get rid of it because it's not slough. I don't want you to degrade it. I want you to call it a stage 2. So here's some examples of stage 2 ulcers on the lateral heel, the thigh and the scrotum from that Foley catheter. And then the one on the right is a patient who got stage 2s from lying in a prone position on the operating room table. So all of these are relatively superficial wounds that have the capacity to heal and should heal relatively quickly if we keep them clean and moist. So the way that a stage 2 ulcer heals is with epithelialization. If you remember back, I didn't like the picture of the skin with the big hair in it. Well, here is where I realized I needed it. The epithelial cells that cause a stage 2 to heal come from either the edges of the wound or the follicle around the hair. So if you want to flip back to slide 1 real quick, you'll see that the hair follicle is actually lined with epidermal cells. Those epidermal cells dip into the epidermis, and they are what come up. They pop up, and they sometimes cause little islands of epidermal cells to sit there, and then eventually they come together. The stage 2 doesn't have a lot of contracture with its healing. It doesn't need to unless it's extremely large. And very seldom do we get pigmentation back because the pigmentation of our skin comes from the melanocytes, and the melanocytes are in the epidermis. So you may see a patient with incontinence-associated dermatitis that seems to be relatively superficial, but once it heals, it stays a different color because it's certainly through the melanocytes. Here's the stage 3. I love the artwork. Hope you like the artwork. Extending into the fat, little pieces of fluff sitting in that wound bed. So these are full thickness loss of skin in which the adipose fat is visible, and there's often, depending on when you see this wound, if you see it early, there won't be granulation tissue, but within a couple of days there should be granulation tissue, and then as it ages, it gets something called epibole. Fluff and eschar may be visible in these wounds, and one of the questions that NPOAP gets often is how deep is the stage 3, how deep is the stage 2, because the electronic medical record forces you to take a depth measurement. People say, well, if I say it's less than 0.1, does that automatically make it a stage 2 or a stage 3? And I can't tell you that because it depends on where you're at. We don't have a lot of pressure ulcers of eyelids, but can you imagine how thin that wound would be? Because eyelid tissue is extremely thin. Where stage 2 or 3 of the buttocks could be a totally different look, and we just looked at a fairly thick stage 2 on the last slide. These stage 3 ulcers, full thickness ulcers, do have undermining and tunneling. Fascia, muscle, tendon, ligament, cartilage, bone is not exposed. That is the tissue that is characteristic of a 4. And then if you can't see it, you can't tell, it becomes what's called an unstageable pressure injury. So one of the words we used in this definition was the word epibole, and epibole means a rolled edge. It is a sign of an older wound. It's been around a while, and what's happened is the epidermal cells have tried to crawl across the open wound bed, but there's nothing to support them. There's literally no scaffolding because it has not filled with enough granulation tissue yet. And so they turn onto themselves, and when they touch each other, they stop. They will not crawl down the side of the wound and cause it to close. It needs to be removed. Some people call this freshening up the wound edges. I love that. It sounds like you go to a spa and have yourself freshened up. You have a facial for your stage 3 pressure injury. I just think it's a funny term. But anyway, the epibole needs to be removed. So stage 3 pressure injuries heal differently. They heal by granulation tissue. Granulation tissue is actually buds of capillary. And when you see it, it means that there's good blood flow to the wound. If you're seeing pale granulation tissue, that's patient who does not have good blood flow, that granulation tissue is going to struggle to survive. So be sure you keep that wound warm. Whatever you need to do to try to keep it warmer, to keep as much blood flow to that tissue as you can. They also heal with contracture. If you look at both of these pictures, you see the wound trying to pull itself closed, and that contracture process is what creates the epibole that we just talked about. And then they finally epithelialize, but they create a lot of scar as they heal, depending on the size of the wound. The scar tissue is not the same as the native tissue, and it remains quite fragile for at least a year, even if you don't injure it. So plan on an upscaled plan of care for these patients for at least a year after the pressure ulcer is healed. Now, you can see in the bottom picture, that's an ulcer sitting inside of that scar. Those are a problem. I know they're a problem clinically, but they're also a problem to identify. Because one of the old statements by NPOAP was that once a stage 4, always a stage 4. Well, this is and was a stage 4. So when you look at that ulcer in that photo, you think to yourself, I have to call it a stage 4. I want you to hesitate on that for a minute, because if I'm looking over your shoulder and you tell me that's a stage 4, what do you think I'm looking for? I'm looking for some kind of very aggressive wound care. Looking for packing, I'm looking for an upscaled bed, I'm looking for more nutrition, I'm looking for a number of things, and you're probably not going to provide it for a scar wound that's that big. NPOAP has a task force right now that's looking at this issue of how do you appropriately label a wound like that. And my recommendation for you now is to call it an ulcerated scar rather than a stage 4. I realize your documents may force you to do something like call it a stage 4. And if that's the case, be sure you clarify for people looking over your shoulder that that is ulcerated scar, so that we now are putting this patient in a silicone dressing to try to get the scar softer so it will go on to heal. Little bit different problem. The appearance of the ulcer can have slough. I put a pronouncer in. It's pronounced S-L-U-F, slough, not slough, not slough. I've heard all sorts of pronunciations. Slough is actually not tissue. It's dried inflammatory fluid that's usually moist and stringy and yellow, all sorts of colors, depending on how dry it is and depending on the bacteria in it. I'm anxious to start a study to see if we can figure out what bacteria cause what kinds of slough, because the reason the wound is inflamed is something called biofilm. And the biofilm is the house, if you will, of bacteria. So if bacteria are in the wound and creating a biofilm, the wound gets inflamed. And when the wound is inflamed, it creates slough. Eschar actually is dead cells, and eschar is black, brown, or tan. If you're struggling to figure out the difference, I'll challenge you with this. If you take a scalpel and take off eschar and take it down to a nice, bloody, healthy-looking base, it will not come back unless there's an infection in the wound or something major. If you take slough off, you could use a scalpel, but let's say you take slough off or something, it comes right back, doesn't it? Because if you don't get rid of the biofilm, you won't get rid of the slough. So think about your wound practices and what topicals you might be using to get rid of the biofilm to get rid of the slough. Slough will come back. I guess it's job security, because until we get rid of the biofilm, A, the wound won't heal, and B, we're going to have slough every couple days. So here's some examples of stage 3 ulcers, the ischium, the sacrum, and the heel. And you can see the viability of the granulation tissue being very different, isn't it? Take a look at how red and robust that granulation tissue is in the sacrum and even on the rest of the buttocks. And then take a look at the heel, and you can tell with the patient, just by looking at the photo, you can tell that this patient does not have good blood flow. And so we're going to be extremely careful to keep that foot protected and warm to give it the best chance we've got for healing. Stage 4, pretty much the same definition as stage 3. The only difference is we have now reached muscle, bone, fascia, ligaments, etc. Everything else looks the same. So this is pretty much the same artwork. The artist just dropped down and picked up the bone. And you can see in the art that the bone is dark, indicating osteomyelitis is present. And osteomyelitis is certainly a huge risk factor in these patients. NPOAP is asked a lot, how deep is a stage 4? And the answer is, I don't know. It depends on what body part you're in. So in the buttocks that you're looking at that's exposing muscle, that's a pretty deep wound. You're a good 2 centimeters down. The bone, that's the metatarsal head that's sitting there on the side of the foot, that you're at the surface of the skin. And the Achilles tendon, of course, is right under the skin. So there's no surface or no depth to those at all. So don't think that you have to have a certain depth to have a certain stage. That's not what they mean. An unstageable pressure injury is one in which I don't know, basically. The wound is either covered with eschar or slough. So we called it an obscured full-thickness skin and tissue loss because our belief is that the injury extends all the way down, and I don't know if it's a 3 or a 4, and I won't know until the eschar or slough is removed. A word of caution that if you have stable eschar on a heel and it's on an ischemic limb, that it should not be removed or softened. I still see patients that somebody said, well, we've got to get that eschar off your heel, so let's put you in bacon soaks. Let's put you in Epsom salts, all sorts of things. And it's very dangerous because this is the patient who doesn't have good blood flow, and it will very quickly deteriorate. So treat those very differently. Here's some unstageables. And the unstageable injury on the sacrum will have to be surgically debrided. That's a massive wound, unless this patient is at end of life and doesn't want that. The patient in the middle developed that unstageable ulcer in about 36 hours. Was placed on non-invasive positive pressure mask in the emergency room and was ulcerated by the following morning. And the one on the right is an unstageable on the lateral heel. That may be stable eschar. It may be unstable. What you would need to do is see if those edges from 3 to 4:30 and they're about 8 o'clock are lifted or not. If they are adhered to the foot, then I would leave that eschar alone. If they have started to lift, then you're going to have to take it off because then bacteria could easily creep under that edge. The deep tissue pressure injury stage actually underwent a fair amount of revision. And the original definition was written about 12 years ago, and it had lots of things that changed, including our understanding of them. So deep tissue pressure injuries are either intact or non-intact skin with localized areas of persistent non-blanchable deep red, maroon, or purple. And I want to focus on a couple things. One is the word persistent. Deep tissue injury either gets better or worse. It does not stay the same. So you do not have a patient with a deep tissue injury for a year. Every time she puts her foot down, her foot turns purple. That's not deep tissue injury. It also doesn't go away when you lift the leg. So it persists for about 72 hours. And I'll show you some pictures of that. Then it goes through an epidermal separation where you have a non-viable dark wound bed or a blood blister. Deep tissue injury is extremely painful in people who can tell you of their pain, and it also, to me, has always felt colder. As it goes on, it gets warmer, but initially it's colder, and we see that today with advanced thermography. Very difficult to see these patients if the skin tone is quite dark because the purple just disappears into the darkness of the skin tone. So be on red alert for high-risk patients for deep tissue injury, particularly in those with darker skin pigmentation. Deep tissue injury results from intense and or prolonged pressure and shear. So we have a very unique profile of these patients. They tend to be in the ER for a while, on the OR table for a while, in the cath lab for a while. They might be in the ICU for a while, or they have numbness that they can't tell that they've been resting on the bed for too long. So very different picture than sort of the usual patient with a pressure injury. The wound may evolve rapidly to reveal the actual extent of the tissue injury, and rapidly is about 7 to 10 days. And there are cases where they resolve, and we are trying to get a better handle on the science behind that. Once the wound has opened up and you are able to see subcutaneous tissue, granulation tissue, fascia, muscle, that is then staged the way it looks now. So we would stage it as an unstageable or 3 or 4. We do not use deep tissue pressure injury for all sorts of other purple things, like vascular changes, bruising, neuropathic problems, or dermatologic problems. So this pattern is a kind of typical pattern of the deep tissue injury. You can see on day 1 the purple intact tissue. And I can tell you that 48 hours before that, so you might have day -1, this patient was in the operating room and tipped to their left side for the surgery to go on the right side of their body. Then at day 3, can you see the epidermal lift? You can see what looks like a blister. You can see kind of shreds of skin. But the tissue underneath that blister is not healthy. It's not viable. And that's what allows you to say this is not a stage 2. Because look at all purple that tissue is. This patient was put in a low air loss bed, and by day 10, this ulcer was unstageable. So this wound progressed, evolved because of its nature. It really didn't evolve simply because somebody wasn't doing something right. This was just the nature of deep tissue pressure injury. Deep tissue injury, pressure injury in darkly pigmented skin, to me, looks the same as the injury in the Caucasian or the non-pigmented skin. You can see the blistering. You can see the non-viable. This phase in both the darkly pigmented and lightly pigmented patients can be mistaken for skin tears. And so if you hear about a patient who had a skin tear in a place that normally a pressure ulcer would be found, I want you to think twice about calling it a skin tear. Here's some of the things that can confuse you or fool you about deep tissue pressure injury. The first patient was an anticoagulated patient. The patient on the left was an anticoagulated patient who fell into the bedside stand and got bruising. So yes, it's by the sacrum, it's kind of by the buttocks, but it's not got a history of pressure. The middle patient is a patient in critical care on very high doses of drugs to raise their blood pressure called vasopressor drugs. And so this patient's ischemic, that's got nothing to do with pressure. And the patient on the right actually had coumadin necrosis, and the only reason that you'd know that that wasn't pressure was they were doing some blood work. She had purple spots everywhere else too, so it helped with distinguishing that wasn't a pressure injury at all. Here's some other deep tissue pressure injury examples on the buttocks themselves. You can see the blisters starting to form. And on the lateral heel, you can see the list of the epidermis. You can see what looks like the roof of the epidermis popping off. Medical device-related pressure injury used to be a standalone category. And today, it is part of the cause of pressure injury. So these devices are put on for diagnostic or therapeutic purposes, and the wound that you see usually conforms very closely to the shape of the device. The wounds you're looking at happen in the operating room. This patient with stomach, and where her face was held in place with a face mask, and she ulcerated on her chin. So all the stages of pressure injury can occur from medical devices. Up at the top left, that's a stage 1 of the ear from eyeglasses. Remember I told you that non-medical devices were also included in this. There's the stage 2 we just looked at. The stage 3 on the child's foot, that's an IV, the butterfly of an IV. What tends to happen in kids is people get medical devices in, like IV tubing, IV needles, and they secure them really, really tightly so the child doesn't kick it off or pull it off. And then when the child is fluid resuscitated, the tissue becomes edematous and it becomes a tourniquet. The stage 4 at the bottom is from the trach flange. That one was fatal. The patient eroded that wound through the jugular vein and bled to death. The middle picture, of course, is an NG tube, and the bottom right is a deep tissue injury from an elastic stocking. So those are all the stages of pressure injury from medical devices. Medical devices often happen on mucous membrane. We cannot stage ulcers on mucous membrane because the anatomy is not the same. There's no epidermis or dermis in that tissue, and so I'm giving you a bit of anatomy, the drawing just to show you the difference. The upper layer is epithelium, and then the columnar layer, they've got big nuclei in them. They're kind of a little bit darker pink, are what produce the mucus that makes mucous membrane. And then the purplish tissue is actually the supportive tissue of the mucous membrane. So here's some examples of mucous membrane, endotracheal tubes in both of these pictures, one on the tongue and one on the lip. People have asked if the top of the tongue is mucous membrane. And I guess technically not, but we are classifying it that way because of the proxemics to the rest of the mouth, and so we're not staging those. We're identifying them, but not staging them. So then if more than one tissue type is present, and I think this picture actually has all 6 types of pressure injuries there, we're going to stage to the worst one. So in this instance, it would be unstageable because of the eschar in the center of the wound. So before you do any kind of staging at all, I've been saying this a bit, but just to hammer it home one last time, make sure that the injury is from pressure or pressure in combination with shear, that it's not just anatomically on a spot that normally you see pressure injuries. That if it's a wound, obviously you're looking at more than just pressure injuries. Think about the appearance of all those other types of wounds. And then make sure you get off any loose debris. You might not have as many unstageables as you think once you remove some of the stuff and you can actually see the wound. If you know the date of discovery, get that in your record. It will help you with root cause analysis. I'd like you to use anatomical terms. The butt is not an anatomical term. So it's the left buttocks cheek, the gluteal cleft, the ischial tuberosity, something so we can track them. If you know the medical device that led to the injury, be sure you write it down because your hospital system or your care system is going to want to start tracking on how many ulcers are we getting from these Foley catheters that we just bought, and maybe we need a different Foley catheter. Obviously, it's measurements and then the rest of the rest of the description, the bed of the wound, what the kind of drainage is. So I want to spend the next couple of minutes looking at medical device injuries, and then I'll stop and take some questions. So we looked at these as the type of medical device injuries, and I think when you looked at those pictures, you probably said to yourself, wow, I don't know that we would have called those pressure injuries just a few years ago, right? No, you probably wouldn't have. You might have said to the patient, well, that's just what happens when you have an NG tube, or when you have oxygen tubing on, or when you go to surgery and you're laying on your stomach. And so what's happened is, as every system has dropped down the number of pressure injuries on the sacrum and the heels, we've got all these left over. So if you're doing a pie chart, you're seeing more of the pie chart occupied with pressure injuries from medical devices. So if you're wondering why you didn't pay attention to these before, number one, you might not have even been called to see them. And number two, you might have simply thought, well, it's not a big deal, it's going to heal. But they don't heal. And so we're starting to see lawsuits from these injuries, particularly when they're on the face. And people are leaving the hospitals, leaving long-term care, and saying, I don't think I should have gotten this. I came in for this operation. I'm not sure how I ended up with this wound. So the definition of a medical device ulcer is one that it can sustain pressure from a device. The injury takes on the shape of the device, so you're looking at the Foley catheter, the aspiration port and the inflation port ulcerating the scrotum and inner thigh of this patient. And I don't know if you know that the last time the Foley catheter was redesigned was 1933. And so when you think about that, you think, well, what's changed in those almost 100 years, right? Size of our patients. When we used to put Foley catheters in patients, we had tons of Foley catheter left over. We could tape it anywhere, and today you can't even find it. So it's hugely different, and we need a different design. There's some data, some of the best data I know of is from the state of Minnesota. This is looking at the incidence of Foley catheters in the state. So this is all locations reporting. And you can see they have a high number of ulcers from cervical collars in their hospital settings, immobilizers probably in their long-term care settings. But you can see there's lots of reasons to worry about medical device ulcers. This is that same group, and you can see that 70% of their medical device ulcers were on the head, face, and neck, and I think the risk of scarring in those patients and therefore dissatisfied patients is very high. And if no other reason, take a look at those. 74% of these injuries were not identified until they were full-thickness wounds, and 63%, there was no documentation. Anybody took the device off. Did any inspection of the skin underneath the device. So some areas to work on improving your practice. Tray collars are a common one, and I'll let you read some of this. I realize time is marching away on me here. 66.7% of wounds in one study were from the tray collar, and what normally happens is the faceplate is sutured down really tightly and you can't get a dressing underneath it. So it's important to think about, how can we safely protect the front of the body, but we also lose the ties in the back. And it's patients that have obese skin folds and obese necks, we lose the ties and they lead to ulcers. So here's some ideas that you might take back to your facility. One is, can we cut the sutures around the flange at day 5? And can we work with respiratory therapy to be taking the trach ties down and looking at the skin and patting the back of the neck and getting wider, thicker ties to prevent some of that. From nursing's perspective, I do think nurses should work in an educated manner with trach collars and getting the nurse to understand what her role is with the trach, the flange, the collar, the ties, all of that. So I don't want you simply to drop this into respiratory therapy's lap. I want you to think about, what the nurse's role is. And in successful hospital systems, they have looked at both. They've done both respiratory and nursing to address the issue. Here's the CPAP BiPAP. The problem with these, not only they're visible, but they develop on the bridge of the nose and then across the upper cheekbones. The reason they happen is people's nose skin, on the bridge of the nose is very, very thin, and the ulcers happen very quickly. The best way to prevent these is to look at the CPAP mask itself and see if there's, a better design that you could get. But if you can't, put a foam dressing across the bridge of the nose, particularly one that will wick the water away, because there's a lot of humidity on the expired air, and they tend to get really wet underneath the mask, and that just contributes to the ulceration. Other people switch back and forth from a CPAP mask to a full face mask to a smaller mask, and that reduces the ulcers too. The problem with using different masks is it costs the patient more money because you've got to buy all these different masks. So the dressing idea, I think, is a valuable one to at least start with. If you're seeing oral mucosa ulcers, ask who can rotate the ET tube, who can move it. It should be both nursing and respiratory therapy. And the ET tube should be moved from one side of the mouth to the other each time the patient changes position in bed. And try to work with a device that more easily allows you to move the ET tube rather than tape and ties. They're really difficult to work with. If you're finding that oxygen tubing is your culprit, a couple of ideas. Be sure that you're looking underneath the tubing. You might want to pad the ears, but what I find is the device to pad the ears just slides down the tubing, so it never stays put anyway. And so my better recommendation is to look at silicone oxygen tubing as the way to prevent them. The hospitals that I have worked with that have gone to silicone oxygen tubing have had amazing results. So if you've got a high number of these, you may just want to cut to the chase and get oxygen tubing, because I just find that padding doesn't work. The elastic stockings actually have, if you read the instructions inside of them, it says, do not use on patients with peripheral vascular disease. And yet I think that's all we use them on is people with peripheral vascular disease. So what we see happening, if you look at the bottom picture, this patient, A, has the stocking on the wrong leg. He had a total knee of the right leg, so he has the stocking on the left leg, and he's rolled it down behind his knee. And so we're going to get a tourniquet-like injury. So teach your staff how to remove them a couple times a day to make sure that you give, A, the skin some rest, and you prevent pressure injuries because you're seeing them early on. If you're dealing with cervical collars, this is tough. There is a soft collar that the patient should be changed to as soon as possible. They're applied extremely tightly, probably more tightly than they need to be. If you're seeing ulcers, though, a group in California developed that piece, that attachment to the collar that you see at the top, and they reduced their pressure ulcer or pressure injury rate by 89%. So something to look at if that's what you're seeing. Lots of people ask about NG tubes. You need to think about how are you securing the tube. Is it actually coming out of the narrae, or is it taped so tightly to the cheek that it's causing injury of the nose? NPAP advises that you stage these ulcers by the skin. There is an ulcer in the inside of the nose also, but it's staged to what the skin looks like. I wish we had a better NG tube. If you wanted to invent something, that would be a great one to do. And then the Foley's and the fecal containment systems, in general, they are too short. So try to get them out as soon as you can. Intermittent capping is actually better for urinary. And try to leave some slack in the tubing because it's the design of the tubing that's just too tight inside the peritoneum. Every time I talk about medical devices, I have to ask you if you're reporting your injuries from medical devices to your product manager people. Most nurses have no idea that you can actually report these things, and you should, to the people, value analysis, the product department, whoever, because they need to know that their device is leading to injury. I've seen some improvements lately by manufacturing and trying to get these devices re-engineered to prevent less harm. But the only reason they are doing that is they've heard from enough people that harm is coming from the use of their device. So don't take the hit yourself. Let them know that you have some issues. So I want to thank you for the opportunity to talk to you about the new staging system and medical devices, and thank you for the support you provide to NPAP by coming to our conferences and our webinars and so forth. So let me turn it back to you guys, Emily, for questions, and I'll let you be the guide of when my time is up.
That sounds great. Thank you so much, Dr. Black. So we now have time for questions. So Christina, if you could remind our participants how to get in the queue for questions or comments.
Thank you. We will begin the question and answer session. If you have a question, please press star then 1 on your touch-tone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you are using a speakerphone, you may need to pick up the handset first before pressing the numbers. Once again, if you have a question, please press star then 1 on your touch-tone phone. Once again, if you would like to ask a question, please press star then 1 on your touch-tone phone. We have a question from Bethany Jarrett. Please go ahead.
Hi, can you get CEUs for this?
Great question. This is Emily, and there are nursing CEUs for this webinar, and there will be an evaluation with a certificate automatically generated at the end of the webinar.
Thank you.
Thank you. Our next question comes from Patty Davis. Please go ahead.
I was wondering on slide number 34, we say that it's an unstable injury on the sacrum. Why wouldn't we consider that to be a Kennedy ulcer?
Sure could. I don't know if my slides are still up. I was just going to put it up there. The Kennedy terminal ulcer, there it is. The Kennedy terminal ulcer is an ulcer that appears before the patient dies, and the only way for me to know if that ulcer was a Kennedy ulcer is to know the history of the patient. So, it'd be totally different if I told you this patient was on the operating table for 18 hours versus this patient was dying of terminal cancer, right? So I can't tell you simply by looking at the ulcer that it is such an ulcer. I'd have to know the history of the patient, but it could be.
Okay. That's understandable because I was looking at the shape of it, and usually Kennedy ulcers come in the form of a butterfly, and that one kind of has such as a shape of one.
Yeah, the reason that ulcers look like a butterfly is that's the shape of the bones of the pelvis. So the butterfly shape is not unique to the Kennedy terminal ulcer. We still have to look at the story behind the ulcer because we have to make a decision because the presumption is that the Kennedy terminal ulcer is an unavoidable ulcer. Everything was done to prevent the wound and the patient got it anyway. And so I can't make that decision just based on the picture. Attorneys would like it if I could, but I can't.
Okay. Is this another person in the room with me? How would they get their CEUs?
I think you have to get an online evaluation form, and I think you'll get that from the providers of this, if I'm not mistaken. Yep.
Okay, thank you.
And the evaluation is in the chat box at this time. Do you have any other questions on the line?
Yes, we do. Our next question comes from Angela Meesh from Parkview Nursing. Please go ahead.
Hi, it's Angela Meesh. I was just wondering if we could get, is there any way to get this, presentations in color? I don't have a color printer where I work. I mean, they're really good pictures.
Yeah, the pictures are good. The slides are available for sale at NPUAP. The slides that I use for the staging part. I think I turned the slide. Well, obviously, I turned the slides over in color to the organizers. So whether they could print a color handout or not, I would think they could.
Yep, and we do have a handout posted on the LSQ, the Lake Superior Quality Innovation Network nursing home page as well, or www.lsqin.org.
Yeah, and I just want to get it printed. I might just have to see if I can bring it to a printing company then.
Okay, thank you.
Yep, thank you.
Thank you. Our next question comes from Sean Maris from Lone Tree Retirement. Please go ahead. Sean, have you muted your phone? Please unmute it.
Can you hear me?
Yes, please proceed.
Okay. We were just curious, when you have blisters that have occurred that remain closed but are suspected from shearing, how would you classify those?
Stage 2.
Okay.
They're not blood-filled blisters, right?
No.
Yeah, stage 2.
So even if until they're intact and closed, we still stage them as a 2, is that correct?
Right.
Okay. But if not shearing. And if they're not from shearing, we just need medical diagnosis documentation that it's a systemic or otherwise, and that is sufficient?
Yeah, are you thinking of a specific case?
Yes.
Okay. Well, obviously, when you told me they were from shearing, I would think they'd be on the buttocks. I'd be surprised that ulcers from shearing would stay intact because the next shearing would shear off the top of the ulcer. Does that make sense?
Yeah, it's just chronic tissue. It's on like lateral thigh areas.
Oh, I got it. You know, there is such a thing called a chronic friction injury that you guys in long-term care must see a lot of. And I would direct you to an article by Berkey, B-E-R-K-E, and she has a whole litany of colored pictures of chronic friction injuries from people that sit in wheelchairs all day long. And that may be what you have more than a pressure. Those are not pressure ulcers at all. You don't stage them. You don't classify them as pressure ulcers or pressure injuries. B-E-R-K-E is her name. And Emily, if you need me to send that paper to you, I can. If you think that'd be faster than all of them trying to find it.
That would be wonderful. Thank you.
I can send it to you. Chris and I work together, so we kind of have this understanding.
Okay, thanks so much.
Thank you. Our next question comes from Patricia Clinton. Please go ahead.
Hi, I had a question about when somebody breaks down on their nose from their glasses. Occasionally we'll have people with some redness and we're monitoring it. If they do break down, do we call that pressure, or is that more of a friction from the glasses? It's not necessarily that there's something wrong with the nose piece. Sometimes it's just a regular nose piece. There hasn't seemed to be a problem.
Gosh. No, I was not a fan of putting in this other device thing in that definition because of exactly what you're talking about. Are you convinced it's pressure?
Well, it's kind of hard to say. I had a case where somebody actually had the arm of their glasses that was broken, and so then it was rubbing more. Their nose piece was rubbing more on their nose because the arm of the glasses was broken. They didn't tell us that it was broken, and they handled their own glasses, I guess. So they did end up having a scabbed area, and now I have somebody else who at one point did have something similar, but nothing was broken on their glasses, and they've been wearing glasses forever. So I don't know if it's like the weight of the glasses or, you know, sometimes those silicone foam pieces or wherever they are on the glasses, it gets moisture underneath it just from their skin resting against that pad.
Right. Right.
I would love to call it,
I would love to call it a traumatic injury if it was from your glasses just not fitting right, rather than a pressure ulcer. Because the problem, if you call it a pressure injury, then you have to remove the pressure in order to heal it, right? I mean, isn't that the presumption?
Yeah.
So how are you going to remove the pressure on somebody's glasses? You can't take their glasses off. So I'd want to look at it and think, you know, especially the one who broke the side of the glasses, that's trauma. I mean, that happened because the glasses didn't fit anymore rather than pressure.
Right.
I don't know that I know a clear. You could make an argument either way.
Okay.
The problem is if you call it that, then somebody has to do a care plan on that and figure out how to prevent that. And the answer is, you know, get a new piece for the nose.
Right, and we've done that before for people. We've gotten different nose pieces. If they've only worn the glasses with the plastic rim where they don't actually have a nose piece, we've put those little foam pads on the nose piece. But that doesn't mean they're not still having pressure on their nose from the glasses.
I agree.
Glasses are heavier than others. So
I agree. Yeah. Yeah. No, that's what I said. You can make an argument either way that it's pressure injury or a traumatic injury. You just got to figure out if you're going to call it a pressure injury, how you're going to fix the pressure.
Right.
Yeah.
Okay.
Yeah.
Thank you.
Thank you. Our next question comes from Delani Activist. Please go ahead.
Yeah, I have a question. So back on page 3 for the legalities, would it be appropriate, I mean, I don't even know how to think about the verbiage, risk, you know, on the consent forms as they're coming in. Is there...
Well, so here, I'll tell you the story, and I'm glad you asked because I didn't want to bring it up. You cannot put on a consent form that the patient's at risk of what could be perceived as malpractice. You can't. So my daughter's a lawyer, so I asked her this, and she said you cannot. The patient cannot consent to what could be classified as malpractice. Makes sense.
Oh, okay.
I know. I thought that was the answer. You can see where I was going with that.
Yeah. Okay. All right. Well, you know, it would be great if that could happen, but yeah, that answers my question. If there was any kind of verbiage that you could legally put on there. So, and another question, was it B-E-R-K-E?
Yes, B-E-R-K-E. Yeah, Berkey. Yeah.
I just wanted to make sure I heard that correctly. All right. Well, thank you so much.
You're welcome.
Thank you. And once again, if you'd like to ask a question, please press star then one on your touch-tone phone. We have no further questions at this time.
Thank you very much.
Thank you so much, and I just want to check the chat box for any additional questions that haven't already been addressed. Anything new?
No additional questions.
Thank you, Diane. All right, well, this concludes. Go ahead.
Oh, yes, one question has just chimed up. Should we take that now?
Sounds good, thank you.
Tamara Arms, please, go ahead.
If my cohort here in my office didn't get registered, how can she go about doing that? Like, she listened to the whole seminar with me, but I didn't put her name in.
For the continuing education credit?
Correct. Yeah.
Yeah, if you could just send me an email, Emily Nelson. My email address will come into the chat box shortly.
Okay.
We can look into that for you. Thank you.
Okay, thanks.
Any additional questions for the phone?
Yes, another question has just typed up again from Delana Activist. Please go ahead.
Okay, sorry. I was not able to get, because we had 3 people in the room. So I was not able to get into the actual visual webinar, so we called in. So how would I get those names to you then? Hello?
Yep, if you could just send Emily Nelson an email. My email is ENEILSON@METASTAR.com. And I'll follow up with you on that.
Okay,
Thank you so much. Yep, Nelson.
Nelson, okay.
At Metastar, METASTAR.com.
Is it MET?
ASTAR.
Eschar, sorry.
That's okay.
Not the best. So I'm going to read this back. E. Nelson, with an O, at metastar.com.
You got it. Thank you so much.
Thank you. Okay, bye.
Thank you. We have no further questions.
Okay, then. Thank you so much. This concludes this educational session. Thank you again, Dr. Beck, for the evaluation. A link to the evaluation is also included in the chat box. Please take a minute to provide feedback on today's session. Once you've completed the evaluation, you will receive a certificate with the CE credits. This session was recorded and will be available on the Lake Superior Quality Innovation Network YouTube channel in about 2 weeks. Thank you so much for participating today.
Thank you, and thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.